is episode 72 of the Real World Wellness Podcast. Hi everyone, I'm Christine Lehman, a nutritional therapy practitioner and the reverse diabetes coach, which is also the name of my website. I see clients in person and remotely, and I'm accepting a limited number of clients now. You can reach me using my contact form on my website or at christine@reversediabetescoach.com. Please remember while you're listening to the show, advice and information we provide is intended to be helpful and informative, but is not a substitute for medical advice or treatment. I want to welcome Dr. Manal Abdelmalek to the show today to talk about non-alcoholic fatty liver disease, which is abbreviated as NAFLD. Dr. Abdelmalek is an associate professor of medicine at Duke University. She received her medical doctorate from the University of Missouri and then completed her medical residency at the Mayo School of Health Sciences. She then completed a fellowship in gastroenterology at Mayo. Her research interests include metabolic liver disease, particularly obesity-related liver disease, and its association with complications of the insulin resistance syndrome. She is interested in studying the clinical, environmental, and genetic risk factors for non-alcoholic fatty liver disease, new therapeutic options for treatment, and evaluating the impact of NAFLD from a public health perspective. So welcome.
Thank you.
So I wanted to start the conversation off by asking what triggered your interest in medicine and then more specifically gastroenterology.
Well, what triggered my interest in medicine is the opportunity to care for an individual to optimize and improve quality of life through improvement in health. And I was always very touched by the physicians who had cared for various family members along the way and how impactful that can be when one is under excellent medical care. During my residency, I became interested in gastroenterology when I saw a smattering of patients who had developed chronic liver disease and cirrhosis for whom there was no explanation. They adamantly denied drinking alcohol. They did all the right things in life. And their only potential risk factor for that liver disease was nutrition and gaining weight. And I was very perplexed by this phenomena. And that ignited my interest to not only be a liver specialist, but to focus more at the time, and this was nearly 20 years ago, on what appeared to be an enigma in healthcare where there was no answers and the root cause of cirrhosis was unknown.
Mm-hmm. Yeah, that's fascinating. Just to give listeners an idea of the scope of NAFLD, how many people do you think are diagnosed with it annually?
Well, how many people are diagnosed with it is really unknown because I think as a healthcare community, we still have ways to go with educating providers on this entity. Many years ago, fat in the liver was thought to be normal, and a little elevation of liver enzymes also thought to be potentially normal. And it's only in the past decade that we've really grown to recognize that NAFLD or NAFLD, fatty liver disease in non-alcoholics, is a progressive liver disease that can result in cirrhosis. And the current estimates would suggest that nearly 25 to 30% of the U.S. population may have fatty liver disease. How often it's diagnosed, on the other hand, is a question that hasn't been well studied because it's a silent disease and typically one for which there is no symptoms. So it tends to be diagnosed accidentally when patients are undergoing a health checkup or an insurance physical and liver enzymes are noted to be a little elevated, or they go into their physician's office complaining of vague right upper quadrant abdominal pain, but an evaluation of the gallbladder is otherwise unrevealing, or they're picked up incidentally because imaging studies were done for other reasons, and incidentally noted was a fatty liver on that imaging study. So there is no systematic approach to the diagnosis currently.
How would you explain the difference between this and the alcoholic form of liver disease? What are some of the key differences?
Well, the key differences between alcoholic fatty liver and non-alcoholic fatty liver is the use of alcohol. Patients who have alcohol-related fatty liver disease typically would drink more than 20 to 30 grams of alcohol daily. And on average, that's about more than two glasses of wine. And they will also develop elevated liver enzymes and fatty appearing liver on ultrasound. And even on a liver biopsy, alcoholic fatty liver disease can look very much like non-alcoholic fatty liver. The only difference is the threshold of alcohol consumption. So by definition, patients who are defined as non-alcoholic fatty liver disease drink no alcohol or very low levels of social alcohol use that don't exceed that threshold of daily consumption of more than 20 to 30 grams a day.
So if you're drinking in moderation, that is not necessarily a risk factor for either type.
Correct.
And then you also use the term cirrhosis. Can you explain what cirrhosis of the liver is?
So cirrhosis of the liver, cirrhosis is a Latin word for scar. And cirrhosis of the liver is the progression of fibrosis or early scar tissue to a stage that is advanced enough that the liver in its entirety has been replaced by scarring. And once the liver becomes scarred or has cirrhosis, there is a risk of complications of end-stage liver disease. There is a risk that the liver function itself may decline and that the liver may not process protein or nutrients or clear bilirubin in the manner that it should, or even a risk of complications related to increased pressure in the main vein called the portal vein, or what we call portal hypertension, because of a scarred liver, and that can result in fluid accumulation in the abdomen, or what is called ascites, or increased varicose veins in the esophagus, what are called esophageal varices, that are at risk for rupturing or bleeding. Also, patients with cirrhosis are at slightly increased risk for liver cancer. So it's only once patients develop cirrhosis that the risk of health complications that increase morbidity or mortality, risk of death, or need for transplantation goes up.
And that cirrhosis is possible with either or both non-alcoholic and the alcoholic types of liver disease?
Yes, certainly.
So I've also seen the term non-alcoholic steatohepatitis. I don't know if I'm pronouncing it correctly. It's the STEATO hepatitis. Can you explain what that is?
So non-alcoholic steatohepatitis is within the spectrum of non-alcoholic fatty liver disease. Steato meaning fat and hepatitis meaning inflammation. So steatohepatitis is inflammation in the liver due to fatty accumulation. And so it is an interim stage, if you will, where patients could initially develop simple fat in the liver, but 25% of patients who have simple fat in the liver, or NAFLD, will go on to have steatohepatitis or NASH. It's those patients that have inflammation in the liver that are at highest risk for progression with scarring to fibrosis and cirrhosis. In the absence of inflammation, there is little to no risk of scarring. The same principles hold true for any form of inflammation in one's body. One needs injury in order to develop scar. And so the acronym acronym of NASH, or non-alcoholic steatohepatitis, defines those patients who have fatty liver disease who also have inflammation and injury.
That was really interesting. So if I understood you correctly, if you were at the very early stages of developing fatty liver disease, it may not lead to cirrhosis. It could just be sort of a steady state, or how would you characterize that?
If patients have simple fat in the liver without liver injury, they may likely live and die with this and not of this. Patients who develop NASH and fibrosis or progress to cirrhosis are much higher risk of developing a complication related to liver disease in their lifetime.
So if someone were to have a little bit of excess fat in their liver and a little bit of elevated enzymes, what is the approach to that?
Well, I think it depends on the scenario. A little bit of fat in the liver in somebody who has normal liver enzymes and is otherwise quite young, 18-year-old, 20-year-old, away to college, not eating right, sodas and pizzas and the Western-style diet, may be at very low risk. What they may need is lifestyle modification and a better diet, and that fat may clear from the liver. However, if you take the scenario and you're dealing with somebody who has already metabolic syndrome, they're obese, they're diabetic, they have a high blood pressure, high cholesterol, and they're middle-aged with liver enzymes and a fatty appearing liver, the stakes are a little higher in that kind of scenario, and there's risk for steatohepatitis. The presence of elevated liver enzymes in a patient with fatty liver disease is an indication for steatohepatitis, and those patients should seek further evaluation, particularly to stage the severity of their liver disease, because that will guide future care and management.
And that makes sense. I was glad to hear that you can kind of reverse a more simple state in a younger person with lifestyle, because I was wondering about that, the role of lifestyle changes in this, both from a prevention and a treatment standpoint.
Well, the lifestyle changes is the foundation for treatment of fatty liver disease, irrespective of where we are in the spectrum. And with effective lifestyle changes, and particularly weight loss in those that are overweight or obese, improvements in liver enzymes or even improvements in the severity of liver disease can be achieved.
Oh, that's great. So let's talk about, again, we've touched on, I think, some, but the clinical risk factors. I know you've done some research on the association with obesity. Do you want to talk about that? And then we can talk about insulin resistance and some other issues.
So I think this is the story of the chicken and egg. Which comes first? The chicken or the egg? The insulin resistance and the obesity and the insulin resistance. These phenomena are very intimately intertwined, and we've only come to recognize that fatty liver disease is in fact the hepatic manifestation of the metabolic syndrome. In other words, they go hand in hand. If you have metabolic syndrome and fatty liver, they're one and the same pathogenic process, the same root cause, if you will. And so as patients gain weight, they become more insulin resistant, and likewise patients who are a little insulin resistant are more prone to gaining weight. And so both obesity and insulin resistance are contributors to the development and the risk for progression of fatty liver disease. Interestingly, there's even data to suggest that the presence of fatty liver disease may worsen insulin resistance or even be a risk factor for diabetes in the future. So all of these conditions are very interconnected.
Right. And when we talk about NAFLD, the similarities, are there many with visceral fat? Is that kind of similar, or are there some differences?
So certainly visceral fat is a risk factor for complications of metabolic syndrome. Even cardiovascular disease. Patients who carry their weight predominantly in their trunk, truncal obesity or abdominal increase in weight, or have weight in the viscera are at increased risk not only for heart disease and for diabetes, but also for fatty liver disease. We've grown to recognize that there is a phenomena of healthy obesity. There are patients who can carry a substantial amount of weight, and because of how that weight is distributed peripherally as opposed to centrally or even viscerally, they seem to develop no consequences of their weight gain. No hypertension, no cholesterol, no diabetes, no fatty liver disease even. That tends to be people, if we can be stereotypic about body morphology, or the pears as opposed to maybe the apples in their weight distribution. And so how one carries weight and where that weight and that fat is distributed in the body are in themselves risk factors for organ injury.
Now, my understanding in terms of etiology is that the visceral fat literally is sort of wrapped around the organs. Is that how you would describe it?
Visceral fat is either wrapped around the organs in the omentum of the abdomen, which is the connective tissue that keeps all our organs connected. So visceral fat can be inside an organ or surrounding an organ.
And that's what is risky.
That's correct.
As opposed to a more, I guess, superficial distribution of weight, or
what we call peripheral.
Peripheral. So that's an important point that doesn't come out always in these public health campaigns about obesity. You know, the message is often just lose weight, but we're really saying, you know, it's not just weight that's a risk factor. It's the location or the type of fat that you have.
That's correct, and it's not just weight. So weight in and of itself isn't necessarily a risk factor for fatty liver disease. Weight in the presence of insulin resistance is a risk factor for fatty liver disease. So there are patients who may be slightly overweight who have no fatty liver disease, and there are others who may be significantly overweight, but how they carry that weight and where that weight is distributed may have no fatty liver disease. So the trigger or risk factor for fatty liver disease is in part weight gain, but there are other variables that have to come together that culminate in whether somebody is protected or not protected and at risk for disease progression. The things that can culminate into, if you will, badness or negative clinical outcomes are in part one's heritage and genetic ethnicity. We've recognized that patients of Hispanic heritage or Asian heritage may develop non-alcoholic steatohepatitis or NASH, even at lower body mass indexes. The diet is an important risk factor. Diets that are high in hydrogenated fats and excess sugars, the classic Western style diet, is a risk factor for fatty liver disease. Diabetes, well-established diabetes or pre-diabetes is the strongest predictor of fibrosis and cirrhosis. And other variables such as low HDL cholesterol or other complications of metabolic syndrome and weight gain, such as obstructive sleep apnea. The more features of metabolic syndrome one has, and the more genetic or even dietary risks, which are in part modifiable, the diet and the physical activity, all of those culminate into the risk of disease progression. So not any one variable or factor stands alone, and certainly the weakest of those is just weight alone.
Mm-hmm. So when someone brings their lab test, they usually I ask for their lab tests when I see clients. And as you heard earlier, I do specialize in reversing diabetes. I try to prevent it, but I don't always get those clients. So I was wondering, what specific things would someone with type 2 diabetes, should they be tested for? Is that a routine test? I know bilirubin is one, but are there other tests that should be performed on, like diagnostic tests that you recommend?
For fatty liver disease?
Right, to help detect whether they have either cirrhosis, where they stand with the health of their liver.
Right. So it hasn't routinely been practiced and was only recently incorporated into the practice guidelines for the management of diabetes. But I would recommend that a diabetic get, at the very least, an assessment of liver enzymes. And if they are mildly elevated or even, and what I mean by that is for a woman, the alanine aminotransferase, or ALT level, is higher than 20, and for a man, higher than 30 units per liter. If liver enzymes are elevated, it certainly warrants maybe an ultrasound of the liver to ensure whether it's a normal appearing liver or fatty liver. And then if there is evidence of elevated liver enzymes, even with or without the fatty liver, on ultrasound, the presence of elevated liver enzymes is one that suggests underlying hepatitis, and the etiology of that hepatitis and the staging of the severity of liver disease is one that should be performed.
Mm-hmm. Yeah, that makes sense. Now, I, as a child, had hepatitis, and but so in and of itself, that doesn't mean you're going to have type 2 diabetes. We're talking about the whole picture here.
No, the hepatitis is a generic word for just inflammation of the liver, and there are many, many, many causes of just hepatitis, some that come and go, for which there is no consequence or long-term risk, and there are various types of hepatitis. There is hepatitis B from virus B, or hepatitis C from virus C, or hepatitis A, which can be a foodborne virus that has no long-term sequela. There could be hepatitis from autoimmune illness, such as autoimmune hepatitis, and sometimes certain medications can can cause the liver enzymes to be elevated, and what we call a medication or drug-induced hepatitis. So not all causes of elevated liver enzymes in diabetics are absolutely fatty liver disease, and thus elevated liver enzymes should always be evaluated and other blood tests performed to ensure that we're not missing alternative causes.
Mm-hmm. Yeah, absolutely. So going back to medications, are there specific medications that would elevate liver enzymes?
Well, certain medications that can elevate liver enzymes could be excess use or high use of non-steroidal anti-inflammatory medications. Other medications that can elevate liver enzymes could be antibiotics at times, which are transient, estrogen hormonal replacement therapy. The lists are endless, and when one has elevated liver enzymes, the physician, of course, should reconcile the medications that are being taken and ensure that any identifiable medication is temporarily held or stopped with liver enzymes reassessed. But certainly there are several classes of medications that can sometimes elevate liver enzymes in certain individuals.
Mm-hmm. Yes, because I often get some pretty complex cases with their where patients are on several medications. So I was also wondering about environmental risk factors. What are some of those?
For fatty liver disease?
Yes.
Well, I think environmental risk factors for fatty liver disease are fast foods. We are a society on the go. We have gravitated more towards eating out of boxes, bags, bottles, and cans. And nature is going maybe the best way in these situations. And certainly the fast food manner of eating and eating on the run is a risk factor because such foods tend to be much higher in calories and in fats and in sugars. So that's one environmental risk factor. Another environmental risk factor, I think, is the computer era. We are bound to our computer screens, our televisions, our iPads, our iPhones, and in general have gravitated to being less physically active as a society. We don't play outdoors as much as we used to. We don't walk, we don't run, we aren't as physically active because the electronic era has made entertainment a different form of entertainment, and that form of entertainment requires some sedentary principles to it. And so I think the computer era, the electronic era, is in and of itself an environmental risk factor. Those are two big ones, and I think there is some data to suggest that maybe smoking and poor sleep may be also risk factors. And certainly excess use of alcohol could increase the risk of developing alcoholic hepatitis or alcohol-related fatty liver disease and cirrhosis. We do need more research on the modifiable environmental risk factor as they contribute to fatty liver disease.
So I know you're also looking at the public health impact, and from a public health perspective, what do you think should be the main messages and how in terms of preventing as well?
Well, from a public health standpoint, this has been deemed an epidemic. If we are unable to curb the rise in obesity and diabetes in our country, we will invariably see a worsening epidemic of complications that also include a rising prevalence of cirrhosis of the liver due to non-alcoholic fatty liver disease. And in fact, as we've become so successful in treating other forms of liver disease, such as hepatitis B and hepatitis C, we've seen a drop in those conditions and a continued rise in complications and cirrhosis related to non-alcoholic fatty liver disease. The burden is so high that I'm concerned our healthcare systems and our society will not be able to absorb the downstream health economics or the burden that this epidemic will place on the need for organ transplantation or liver transplantation in the future. So prevention, the primary prevention of the problem before the problem progresses is key. It's key to our next generation, it's key to our existing society, and it's key to the implications that this epidemic of non-alcoholic fatty liver disease will have on healthcare resources and healthcare economics. Fatty liver disease, NASH, and even fibrosis and cirrhosis in certain portions of the population that are only mildly overweight or have body mass indexes that are between 25 and 30.
Mm-hmm.
So I don't think any one person can look in the mirror and say, I'm not at risk.
Mm-hmm.
So an assessment of risk would be one that could be discerned with routine health assessments to ensure that one does not have high cholesterol, elevated blood sugar, early evidence of insulin resistance, normal liver enzymes, and I don't think that can be done by looking in the mirror and saying, no, this isn't, this doesn't affect me. I'm doing all the right things. And so I would encourage that patients engage their doctor, particularly if there is family history of liver disease or family history of cardiovascular disease or diabetes, or if there's mild overweight or obese status with themselves or other family members, to evaluate that risk as opposed to looking in the mirror and saying, I'm not at risk, or dismissing potential risk if it exists.
Mm-hmm. No, that's very good advice. I had a client with type 2 diabetes who did engage in a kind of a clinical study where he was diagnosed with sleep apnea, and he went for the longest time without doing anything about it. So I became what I call a professional nag and insisted that he get an appointment and see a specialist for that, because I knew that was impacting many things. He had the insulin resistance and the type 2 diabetes already. So I think that's another factor that often maybe gets overlooked in this whole discussion, the role of sleep and sleep apnea.
Absolutely.
Mm-hmm. You mentioned, when we're talking about genetic risk factors, you mentioned people of Hispanic and Asian heritage. Are those two ethnicities the most at risk? Is that what you're saying, of NAFLD?
Well, I don't know that they're the most at risk. Certainly, this does appear to also be a predominant disease of Caucasian Americans. What I was saying is that there are sometimes people at risk who can develop this at lower body mass indexes than what we would otherwise see in the typical Western countries. And so there are certain genetic polymorphisms that may increase that risk, one being a gene called PNPLA3 that has been identified and validated in several studies to be a risk factor for fatty liver disease and fibrosis progression, but that's probably not the only polymorphism genetically. And so in general, there are different manifestations at various body masses, or maybe even with potentially different environmental risks for different ethnic cohorts. And certainly, interestingly, fatty liver disease does not seem to affect patients of African American heritage as much as it does in Caucasians, or with the same level of severity. Why that is, we still don't know, but it certainly doesn't appear that anybody is absolved of any such risk, because there certainly are enough genetic and environmental risk factors that everybody, that there's nobody who is remiss of that risk, especially in the current Western world.
Mm-hmm. Which reminds me, how does the U.S. compare to, let's say, countries in Europe in terms of the numbers?
Well, certainly this is a condition that is on the rise and appears to be increasing in industrialized countries. So while we have historically not envisioned complications of obesity occurring in underserved and underprivileged countries as they are becoming more industrialized and gravitating more towards Western lifestyles with fast food and with also sedentary lifestyles. Fatty liver disease is also increasing in other places around the world. Mm-hmm. It's been described in South America, in India, in China, in Asia, certain parts of Africa. Mm-hmm. And so this is a global problem.
Mm-hmm. Yeah. I always, when I have conversations from people with other countries, developing, I guess, countries such as India or even from Mexico, when we end up talking about diet, and I usually end up saying don't emulate necessarily what we're doing here because it's led to some real problems. And just, getting access to fresh food and having the markets and so on is, Whole Foods is just really the healthiest way to go.
Agreed.
So the other thing I was wondering is for people who are already further along on this progression, what are the treatment options? For example, if they have cirrhosis of the liver, what are some of the more promising, I guess, treatment options at that point, or are there?
Well, currently there are no FDA-approved therapies for non-alcoholic fatty liver disease. And that's why I say that the foundation of current therapy is lifestyle modification. Mm-hmm. Once patients develop early cirrhosis, what we call bridging fibrosis or well-established cirrhosis, while there may be no therapy to reverse cirrhosis currently, there is diligent care that needs to be lent, as patients who have cirrhosis should be screened for liver cancer annually. Every few years need to be screened for esophageal varices. Blood tests should be monitored periodically to monitor liver function. And if and when complications of their cirrhosis arise, then further evaluation for consideration of liver transplant may need to be made. Fortunately, that is the minority of patients, not the majority of patients that have fatty liver disease. And we're currently estimating that probably only about 5% of patients progress to that level of advanced liver disease overall. There are several compounds that are currently under evaluation and are currently being tested in phase 2 and 3 clinical trials that are designed with the goal of improving steatohepatitis or fibrosis in patients with NAFLD. So I think we have exciting opportunities ahead of us, and hopefully in the future we'll see new therapies on the horizon.
Mm-hmm. Mm-hmm. So it sounds like lifestyle can do a lot to prevent it pre-cirrhosis. It can maybe reverse the condition pre-cirrhosis. Is that correct?
I think so, and the data would suggest that a 3% improvement in weight may help with insulin resistance. A 5% improvement in weight can even help normalize liver enzymes, and if one gets to a point where they can effectively lose 10% or more of their body weight, there can be improvements in underlying liver histology or injury on liver biopsy. So we should not be dismissive of healthy lifestyles and weight loss and exercise.
And one of the other prongs in my approach is stress management. Have you been able to kind of tease out what role stress management, like yoga, meditation, those kinds of alternative medicines, are they helpful in this?
Oh, I certainly think so. There's an entire body of literature on stress and its role of increasing serum cortisol and even worsening insulin resistance. And certainly stress has bearings on sleep cycles, and even stress eating. Patients who are stressed will tend to consume potentially more carbohydrates and sugar in their diet. So I think stress certainly is a facet of fatty liver disease that warrants further research, hasn't been evaluated fully, but other data would suggest that stress is a factor in other risk factors that contribute to fatty liver disease: eating behaviors, sleep, insulin resistance.
Do you know if they've looked at specific supplements at all for helping with this?
Short of vitamin E, that has been evaluated in a pivotal study called the PIVEN study by the Non-Alcoholic Steatohepatitis Clinical Research Network, the NASH CRN, which did demonstrate some improvement in NASH, but not fibrosis. In a phase 2 trial, there has not been excessive large population-based studies looking at health food supplements.
Well, that's really interesting because that's another sort of prong that might be useful in addition to looking at medications.
Absolutely.
So I want to just close with your hope for preventing or treating NAFLD. Is there something that's really stood out to you? You've done a lot of research in this area.
So I think my hope for treating NAFLD is a tiered approach. I hope to increase awareness such that basic interventions such as lifestyle modification, better health food choices, increasing exercise in our society is a foundation for prevention. From a medical standpoint, our primary goal in diagnostics is to develop a biomarker, a blood-based test or an imaging-based test that could empower physicians to cherry pick out of a vast population of patients who's at risk. Because we know that those patients who have advanced liver disease are the ones that are at risk, but on the surface they look like everybody else in the crowd. So we have to find a mechanism by which to identify in 30% of our populations which ones are already have advanced liver disease, so that we can target them appropriately for therapies and for screening and long-term monitoring. Those with mild disease don't need to be need that level of care and monitoring, because they may live and die with their disease and never of it. But I hope we can make significant strides in diagnostics, and my hope is that ultimately we find that breakthrough approach to reversing hepatic fibrosis, because fibrosis of the liver is the primary predictor of bad outcomes. And if we can fix fibrosis and reverse chronic liver injury, we can hopefully deter patients from getting into the negative outcomes of end-stage liver disease and need for transplant or the development of liver cancer. That is my hope. And I'm hopeful that in my lifetime I may be able to see that happen. But I think we have a very earnest, very rapid progression in the field, and I am optimistic that new breakthroughs are on the horizon.
Well, that sounds exciting. So I want to thank you so much for being on the program today, and I'll include the link to your website page and some of the resources and research that we've discussed in the show notes. Next episode, I'll be having a conversation about mindfulness, what it is, mental health and health benefits, and practical tips for starting your own mindfulness practice. So stay tuned for that episode, and feel free to access previous episodes on my podcast page or wherever you get the Real World Wellness podcasts. Be well, everyone, and have a great, healthy week.